everyone. Welcome to our webinar on occupational health trends beyond COVID-19 and new approaches to workers' health. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. Thanks for joining us. I know many of you are here faithfully month to month. We welcome you back, and if you're new, welcome. I just wanted to let you know that we're going to be taking a break over the summer to give Dr. Harris some time off, well-deserved, for him to focus on some other issues, but we will be resuming a version of this in the fall, so we'll keep you informed about that. During the webinar, you'll be on mute. Please submit your questions using the Q&A function in Zoom. I see we already have a couple questions, so you're ahead of the game. The webinar recording will be posted on our YouTube channel as usual. And if there's any questions we don't have time to address during the webinar, we'll transcribe them and have answers on our website. We have the full hour scheduled, and we look forward to hearing from you as we get through the webinar. We'll be taking the questions at the end. As you all know, our presenter is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine, and he is a WorkCare Consulting medical director. And now I'll turn it over to him with a lot of thanks for everything he's done for us up to this point, and wish him well on his summer break. Okay, here we go.
Excellent. Thank you, Karen. And thanks everyone for tuning in once again on our June 1st presentation here. And as Karen mentioned, we will be taking some time off here after this presentation. So we'll keep providing content here in the future, and we'll tell you how we're going to do it as well. But for this series, we'll be taking a couple months off here. So thanks for joining today, and jumping right into our topic for today. We're going to be really dialing in with our same format, clinical update, pathology, epidemiology, and workforce strategies regarding an overall approach to our workforce for a long-term perspective of protecting the workforce, and how do we maximize our efforts to minimize health impacts to the workforce. As you all know, with this format, we'll talk about the clinical, we'll deep dive into the pathology. We'll talk differently about the epi today than what we have in the past, or how we've described it in the past. And that'll be self-explanatory as we get there. And then finally, we'll get and spend quite a bit of time on strategies to help mitigate workplace health effects from not just the pandemic that we've experienced so far with COVID, but for other health outcomes that impact our workforce on the day-to-day that may be adversely impacted because of items like, or happenings like COVID-19. And so when we talk about the clinical impact, as we get into our topic for today, we really want to understand the outcomes that we can expect as a result of COVID-19 from a health perspective of the workforce, okay? And to really zoom out and begin to unpack this, we're going to turn to a study that was conducted and published recently here, February of this year. And this was published in The Lancet. And the researchers here really looked at what is the post-pandemic world impact, health perspective-wise, to the workforce, right? And how has the pandemic and directly COVID-19 impacted our workforce, and to help us understand how we can implement strategies to help protect the workforce, again, from COVID-19 impacts as well as beyond COVID-19 impacts. And so this study really, again, focused in on maintaining the health and well-being of workers from a governmental regulation standpoint, mandating safer work conditions, from anything from improved ventilation, reducing crowding, managing physical and psychosocial risks. And we'll be spending our time here talking about that and more in depth, and other infectious control measurements, as well as supportive leave policies. This also looked at important steps towards uniform protections across industries and jobs, and really, focused in on, are there mandates that should be in place with regard to high risk exposures from workplace hazards, We will be talking about that here briefly and giving a new perspective on that. And then workers in non-standard arrangements, right? Working from home, protections for those who have varied work schedules, et cetera. And how do we eliminate some of the health disparities that exist? And if we focus in on solutions there, we certainly will be in a better position of providing or enhancing our workplace workers' resilience. So when we look at this framework that was published in the Lancet here, it really starts at a high level social, political, economic environment and speaks towards a particular nation's disposition in regards to globalization, technology, and the distribution of jobs. We won't really be focusing at that very high level for this talk. Rather, we're going to zoom in to the enterprise, right? What can we as environmental health and safety professionals focus in on and implement to help augment the impacts, again, from COVID-19 and the post-COVID, and we're still obviously in COVID world here, right? And so when we look at what we can implement, we want to drive towards incomes of resiliency, productivity, turnover reduction, culture of health, right? Those are things we can affect. Those are outcomes that we can modify. And really, it's about creating a thriving workforce around mental health, reducing burnout, and redistributing the balance in regard to healthy behaviors, right? And so that's how we'll spend our time today. I'll send it around, again, this framework, if you would. And when we talk about clear impacts from COVID-19, we've presented this and recently here in past talks on our webinar, right? COVID-19 infections impact the risk of diabetes. That's one of the frameworks we want to, one of the chronic diseases or chronic illnesses that we've spoken to and we want to continue to speak towards today, right? And we looked at and showed the evidence in this publication back in March of this year, examining the impact of and incidence of diabetes from the impact from COVID, right? And we showed clearly that there was a higher risk, right, increased risk hazard for those individuals who had COVID-19 in regards to not just incidence of diabetes, but also increased burden of anti-hyperglycemic use, right? So it was more difficult to manage diabetes after a COVID infection for these individuals, right? And so again, and this was looking at 1,000 people per 1,000 people over a 12-month time period. And again, we showed that diabetes was worsened, not just for the severe hospitalized or intensive care scenarios, but for non-hospitalized individuals as well, right? Again, looking at a burden of 1,000 people over a 12-month time period, there's a clear association of COVID infection increasing the incidence and unfortunately severity of diabetes mellitus, right? And so looking at the next slice of health impacts as we delve again into our clinical examination for today, heart and cardiovascular impacts have soared after COVID-19, even with mild cases, right? And we have showed some of this data previously with the long-term cardiovascular outcomes of COVID-19, in particular, showing from this cohort of veteran affairs individuals, over 153,000 in this particular study that was published by the same group that published the data on the diabetes back in March of 22 of this year. Looking at this cohort of over 5 million, again, this was from VA data. That's why it was so expansive in terms of what they could capture information on. And at the end of the day, showed that burden of cardiovascular illness, right? In particular, looking at cerebral vascular disorders, strokes, dysrhythmias, abnormal rhythm of the heart, ischemic and non-ischemic heart attacks, meaning the heart suffers from lack of blood or suffers from muscular damage, pericarditis, myocarditis, inflammation of the heart, and the covering of the heart, as well as heart failure, all increased as a result of COVID-19 infections after 1 year, longer than after 1 year after COVID infections, again, even in mild cases, right? So we have clear evidence, again, impact of COVID to diabetes, impact of COVID to cardiovascular. And then lastly, we're going to look at impact of COVID to musculoskeletal, right? And I know you're saying, hey, doc, I don't know, this one seems a little bit more far-fetched. That COVID affects musculoskeletal. So let's examine that with some evidence here. This article was published in Sports Health, and this was published recently, May 2022, and it examined via survey runners, over 1,900 runners that met the inclusion criteria for age, the average age being 45, and 56% of the individuals were women. A total of 123 runners self-reported COVID-19, right? Of that, 100 of them had diagnostic criteria from PCR of a positive test. 23 reported that they had a diagnosis, clinical diagnosis from their clinical professional, medical professional. And the results, after adjusting for sex and age and number of races in 2019 versus the pattern in 2020 with COVID infections, there was a higher incidence of injury amongst those that had COVID diagnosis than those who did not have a COVID diagnosis amongst these runners. The odd ratio was 1.66. So again, evidence pointing towards an increased risk of musculoskeletal injury as a result of COVID-19 infection. Again, as we're pointing out this data so that we can try to understand what the impact to our workforce from a musculoskeletal standpoint it may be as a result of COVID-19 infections. And this is why we need to continue, one of the reasons why we need to continue to try to protect the workforce as much as possible from COVID infections, because we know there will be untoward impact that span beyond simply the direct COVID impacts from a respiratory standpoint, cardiovascular, diabetes, musculoskeletal, all right? And when we talk about the pathology then that is driving and trying to understand the drivers behind the impact to the workforce in regards to these and other illnesses, we know and we have shown that it's a multi-organ effect that COVID has, right? And so this study that was published back in 2021 in Frontiers in Microbiology demonstrated that not only was the respiratory system impacted by COVID-19, but in organs such as the kidneys, the liver, etc., right? And we demonstrated this as a result of the inflammatory cascade that results from a COVID infection. The cytokines that are released, the pro-inflammatory chemicals in our body that can drive a cytokine storm and then subsequently impact the brain, the gut, cardiovascular system, the liver, the kidneys, and the microvascular in general, right? Even the eyes, we've seen that impact there. And so we know there's clear evidence that COVID-19 can affect and has affected these underlying pathological pathways. And again, we'll be dealing with this amongst the workforce impact for some time to come, right? We know that, again, 12 months after an infection, individuals are still experiencing fog brain, the difficulty with recall, etc. We know they're going to experience potentially the impact from a diabetic, from a musculoskeletal and cardiovascular standpoint, amongst others. But again, we're focusing in on these individual pathological pathways so that we can speak to what can we do about it, right? How can we as EHS professionals participate in minimizing these effects and again, creating a more healthy, maintaining a more healthy population. So now let's hop into the epidemiology, and we'll save a lot of time here for questions. I know there's going to be questions beyond this presentation about monkeypox and other processes that are happening amongst the U.S. and abroad, and we'll certainly be able to answer those questions. But we really want to drive towards how can we deliver mitigation strategies for our workforce towards trends in wellness, right? If we look at now the macroeconomic trends from an epi standpoint amongst the workforce in terms of drivers of cost, we want to also look at evidence of health behavior as well, right? And so I'd be remiss if I did not present our current state. This is just best practice for this particular talk. We got to mention at least at some point our impact from COVID from an epi standpoint. And certainly you all have experienced and seen the increase in incidence of COVID And we have a little decrease here over the last week in incidents. But again, you have to understand that this incidence that is being tracked with cases per million is likely only a fourth of the at best only a fourth of the actual cases that are occurring in the general population, right? So it's estimated that in some states this number is 10 times higher, and so we take that into effect in regards to the impact to our workforce moving forward, right? But getting back to the economic drivers around costs for our health maintenance of our workforce, right? We want to talk about one of the particular drivers in regards to insurance benefits, right? Healthcare, obviously in the U.S., is driven and paid for by insurance. The largest payer, obviously, being Medicare, Medicaid, and then private insurance. And we're going to speak directly towards to those employers that are self-insured, right? They're self-funded, self-insured, and they you employers bear the risk for the health and well-being and the cost thereof of your workforce, right? And so again, that's one of the tenets that we want to focus in on to help mitigate costs by way of increasing resilience and improving health amongst the workforce. But if we look at the economic trend in this publication back in 2021, we can see that the percentages of, and this was published by in conjunction with some data from CDC, I believe, as well. But this data shows that the percentage of self-insured employers in the private sector has increased over time, right? From 1996 all the way to 2020 with this set of data. And that trend is undergirded by several factors that are happening from an economic standpoint, macroeconomic standpoint. And one of those trends is the cost of healthcare insurance. This data has shown that and on average, premiums as of 2021 are around $7,700 for an individual to be covered, $22,000 rather for a family. And over the last last couple of years, since 2016, we've seen a rise, 4% rise in the average premium for family costs and an individual. All right, 4% increase. And we've seen up to 47% increase if we look all the way back to 2011, and 22% since 2016. So we know there's clear cost increases that are driving employers towards being self-insured because healthcare insurance premiums have continued to go up. And if we look a layer deeper than that in terms of demonstrating what potentially is driving or is the cause of those increased cost of premiums, it's really not attributable to, as shown in this data that was published in 2022, April of this year, not attributable to increases in healthcare utilization, right? So about 2/3 of the increase per person of healthcare spending over the last 5 years is explained through rising costs and not rather utilization increases, all right? And so if we look at the phenomena of consolidation of hospitals and physician practices, that does and has been a factor toward driving up higher prices, right? And this data has come from Kaiser, it's come from University of California and others. And if we look at then the last piece of it, commercial insurers have not passed on economies of scale savings in their premium prices. They've maintained their prices or increased their prices as they've gotten bigger and experienced lower costs of delivering care because of economies of scale, and they've not passed on those cost savings to employers. So again, what do we see? The phenomenon of employers becoming more self-insured, and that again gives us a credence for why we need to ever more participate in the process of not just maintaining, but mitigating healthcare risks more broadly for our workforce population. So going back to the areas in which we want to effectuate change and improvement and increase resilience, we want to focus on 3 areas: metabolic, right, disease. We want to focus on cardiovascular disease, and we want to focus on musculoskeletal disease. Those impact areas I spoke to earlier. And so the first of these, diabetes, we want to understand and unpack this from a workplace standpoint of what could be affecting our workers from a workplace exposure perspective, right? And then that, again, we can speak towards how we mitigate said impact. And in this particular study, we want to look at, from a 2017 publication in Journal of Sleep Research, the impact of night shift on glycemic control, diabetes, with individuals with type 2 diabetes. And in summary, the study showed and demonstrated that circadian rhythms play a role in regulating metabolism. We know this, and that night shift work can impact circadian rhythms and cause misalignment. And that's what's associated with increased risk for poor diabetes control. And in this particular study, with 104 unemployed individuals, 85 daytime workers, and 60 nighttime shift workers that participated, sleep duration, sleep quality, morningness, and eveningness preference, as well as depressive symptoms were examined. And dietary intake was a part of the examination as well in terms of standardization through questionnaires. And as a result of their findings, hemoglobin A1C levels were measured and demonstrated to have increased A1Cs amongst those individuals that have night shift work, right? And it wasn't just night shift work, it was also those who had rotating shifts, right? So it wasn't just night shift work for the individuals that impacted A1C levels, it was having both night shift and rotating schedule that caused the disruption of circadian rhythms and led to, at the end of the day, more difficulty maintaining lower A1Cs, which is directly associated with the maintenance and prevention of diabetic long-term sequelae, meaning impact from diabetes, right? So again, this was adjusted for all the factors I mentioned earlier: sleep duration, preference of morning, evening, etc., and the actual number associated with increased risk for diabetes poor management, i.e. A1C, was 0.059, while there was no differences amongst those individuals who were unemployed versus daytime workers, right? So again, two sets of controls: those unemployed and those daytime workers did not show an increased risk of A1C poor management. All right. So again, exposure from work, work shifts impacting directly our workforce from a poor diabetic control perspective, right? And if we look at another a perspective of diabetic control and diabetic impact, this study that was published in 2019 looked at looked at the problem a little differently and the impact a little differently, not looking specifically at A1Cs, but rather the individual's self-care, right, in regards to how well they were able to maintain their diabetes and the impact from their subjective complaints as a result of shift work. Okay, so again, looking at shift work impact to individuals with diabetes. And at the end of the day, this cross-sectional study that had 86 participants, those 45 of those individuals day shift, 41 of them evening or night shift, and through questionnaire, in conclusion, showed that diabetes management was more difficult for those individuals who had shift work or nighttime work. And they had more subjective complaints, meaning leg pain, fungal infection, numbness in the feet and legs, dizziness, and visual changes, right? And so again, implications are that workplace exposure, such as shift work, night work, directly impacts and makes worse the experience and subjective complaints of individuals with type 2 diabetes, right? Now jumping up, so when we talk about the cost, jumping into the economics of diabetes, we can see clearly that individuals, even without a diagnosis of diabetes, right? So pre-diabetic, right? And if we look at other data amongst those in the US that are pre-diabetic, 1 out of 4 individuals in the US are pre-diabetic. And what this study that was published in 2021, February, demonstrated is that 5 years preceding the diagnosis of diabetes, the cost from a medical standpoint, medical cost standpoint, begins to substantially go up, right? For newly diagnosed individuals, it's $8,900 increased cost for an individual with diabetes. Over a 5-year period prior to that, right, we're seeing that cost start to escalate. That first year of that 5-year period was $4,800 increase. So again, even 5 years ahead of a diagnosis of diabetes, the medical costs for individuals began to increase. And again, that's why we need to really come up with novel solutions to help mitigate risk for our workforce, not just from a direct cost standpoint, but from an indirect cost standpoint, productivity, absenteeism, presenteeism, et cetera, right? So 9% higher increase amongst subjects who, again, had costs over time in this particular study. So now let's jump into cardiovascular, right? So we've reviewed diabetic, metabolic. We're going to look at cardiovascular, and finally we'll look at musculoskeletal impact. So again, going back to impact of night work, shift work on hypertension. This study published in 2019 demonstrated, well, looked at again the causes of impact to hypertension as a result of both shift work and night work. And the cohort was larger than the studies we've looked at so far, 2,100 individuals who participated for over a time period of 10 years, right? And looking at their hypertension, their high blood pressure. And what was demonstrated that over a 12-month period, looking specifically at the hypertension measurements over that period of time, workers who had night shift and rotational work had an increased incidence of hypertension, right? Increased incidence of not outcome or long-term effects from hypertension, meaning they didn't look at stroke, they didn't look at cardiovascular incidents, but specifically risk for hypertension compared with non-night workers. There was a clear association of increased risk with a hazard ratio of 4 for those individuals who had night shift work or rotational work. Okay, so again, rotational work, night work, increasing risk for cardiovascular disease, particularly hypertension in this case. If we look at another study demonstrating similarly the effect of night shift work on cardiovascular, this particular study examined, this particular study actually is still ongoing, but examined an expansive number of metrics beyond just hypertension, right? Looking at the effect of circadian rhythm disruption from shift work on high blood pressure, atherosclerosis, diabetes, and being overweight. Okay, and so this study looked at it began in 2018. It ended the fourth quarter of last year, 2021. It was amongst 125 individuals. And so we'll continue to follow this set of data and research to see the impact on a number of factors. Again, they looked at resting heart rate, arterial stiffness, and even the thickness of the blood vessels themselves, which is the atherosclerosis, right? And overall fitness of individuals. And so as that data becomes available, we'll report it back so that we can fully understand with those metrics the impact from shift work. And so, again, talking about the cardiovascular effects on individuals here in the U.S., we can see if we look at from a different perspective and break down from an industry at an industry level, individuals who don't meet criteria for healthy cardiovascular status, right? And this is CDC data that was published back in 2016 that did just that, breaking down per industry individuals who have 2 or less criteria met for healthy cardiovascular status, right? And so these factors, not smoking, being physically active, having normal blood pressure, having normal blood glucose, normal weight, normal cholesterol, and eating a healthy diet were the 7 factors examined and broken down by industry. And so if we look at some of the industries in terms of the top 3 industries for having the highest risk factors, meaning they've met the lowest criteria, 2 or less, which substantially increases your risk for cardiovascular disease. We can see that number one was community and social services, two, transportation and material moving, thirdly, architecture and engineering, right? And so again, it's a telling picture of, again, impact to cardiovascular health broken down by industry. And finally, musculoskeletal, right? We want to examine what's the impact from a musculoskeletal standpoint to our workforce, not just from COVID that we spoke to earlier, but overall, what are the metrics that we can examine to help mitigate risk and make our workforce more resilient, right? And so in this case, we can look at and see that over the last, since 2014, the cost of musculoskeletal injuries has not decreased over time. One would have hoped or thought that we had a decreasing trend for cost, but we've just recently continued to go up, even if we look at more recent data up to 2020, and some of the data that's coming out regarding 2021. And so we want to examine some of the theories behind and break down some of the understanding behind musculoskeletal injury and why we may not be as effective as we once had hoped we could be with our interventions that are currently available, and talk about then what are some novel approaches to mitigating musculoskeletal risk for our workforce and making individuals more resilient. Right. And so this first theory regarding musculoskeletal injury really is called the differential fatigue theory, and it really looks at asymmetric occupational activities, right? And it's causing fatigue to have asymmetry in the work that individuals are doing. This is one of the fundamentals behind ergonomic intervention, right? Trying to look at the kinetic and kinematic imbalances and correct for those, right? And so when we look at the next theory, cumulative load theory, this one speaks more towards a load over time exceeding the threshold and range for our physiology, for workers' physiology, right? Through material handling, et cetera. And again, we do account for this level of impact through our classic ergonomic interventions. Overexertion theory similarly talks about overexerting over a period, in a set period of time, the capacity from a physiologic standpoint of individuals, right? And once you cross that threshold of capacity, then you begin to get into the realm of injury, even from a microscopic level of tissue damage, right? And we're beginning to uncover ways to get at this particular, understand and get at ways to intervene through use of tools like wearables to understand the impact to the workforce from even a physiologic overexertion level, right? But this last theory, multivariate interaction theory, looks more broadly at a number of things that we traditionally have not had good means to, one, measure and then intervene, right? And so this theory speaks towards disruption of the in a mechanical fashion of the biologic system, and is dependent on the individual's particular makeup, right, and their particular mechanical properties, their genetic endowment, the morphologic characteristics, and psychosocial makeup, right? And we're looking at that through the lens of occupational biomechanical hazards, right? That multivariant interaction theory is something that presents an opportunity for us if we can find novel ways to both intervene and then make our workforce more resilient. And so it's suggested that, you know, if we can do so in terms of modifying simultaneously these different factors, we can help drive down musculoskeletal injury. So if we kind of go a step deeper into musculoskeletal risk from an underlying kind of individualized approach, this article that was published in the American Journal of Medicine back in 2002, way back in 2002, examined hand disorders and shoulder disorders amongst individuals with diabetes mellitus. And what they found is that these particular diagnoses, adhesive capsulitis Dupuytren's disease, which is a disease of the hand, adhesive capsulitis is usually a shoulder injury that is inflammatory in nature. Flexor tenosynovitis is hand-related typically, that it can be debilitating from a range of motion standpoint and pain standpoint. And carpal tunnel syndrome, most everybody understands CTS, carpal tunnel syndrome. What this particular study found is that the prevalence of these particular disorders from musculoskeletal standpoint was increased in individuals that were diabetic, right? And so adhesive capsulitis, 12% more present in diabetics. None of the control had adhesive capsulitis. Dupuytren's disease, 16% in the diabetics, 3% in controls. Flexor tendinosynovitis, 12% in diabetics, 2% in controls. And carpal tunnel, 12% versus 8% in control, right? And so again, if we can intervene from a underlying factor, we can, in this case, diabetes, we can potentially impact and decrease the risk of musculoskeletal disorders. It's something that we just haven't been able to do well traditionally from an EHS perspective. Finally, let's look at occupational diagnosis of shoulder tendinopathy, patellar tendinitis, and de Quervain's tendinosynovitis. Again, shoulder tendinopathy, disease of the shoulder, patellar tendinitis, jumper's knee, usually presents with pain, swelling, redness. De Quervain's tendinosynovitis, condition of the hand, where the thumb is really affected and can cause pain, stiffness, and reduced range of motion. This particular study that was published in 2015 looked at these particular diagnoses and found amongst the 2,600 participants that were within a met review of 17 studies, individuals had an altered tendon structure, right, at the tendon at the actual tissue level, right, from a result of high cholesterol. And the cholesterol they looked at was LDL, right, the low density lipoprotein. That's the bad cholesterol that we traditionally talk about, and triglycerides, right, as well as a lower high density lipoprotein, which is the good cholesterol. So in short, those individuals that had high LDL, high triglycerides, and low good cholesterol, HDL, had an increased risk of these diagnoses from a musculoskeletal standpoint, right? And this amongst 17 different studies that were examined amongst this study, right? And so again, looking at the predisposers of musculoskeletal injury being the underlying condition of the individual from a chronic disease standpoint, right? And so now we can start to talk about, I know we're approaching the 40-minute mark here, so we'll try to speed things up and get through the rest of this, but we want to talk about the perspective of how do we intervene from a workplace standpoint and strategy and mitigating potential impacts to our workforce and across the enterprise. And again, focus on how do we improve worker resilience? What methodologies can we do? We'll focus in on the vision, right? Being able to see kind of what the trend is amongst EHS professionals so that we can drive effectiveness at these protective measures. And we're really focusing on the vision right now, right? Understanding the vision, and in subsequent talks and presentations, we can talk about the effectiveness, all right? And so workforce population screening is what we can focus on and deliver in today's trend of workplace interventions. And this is no different than what we've experienced with COVID-19 in our role as in EHS in the past, right? We focused in on reducing transmission so that we can hopefully reduce an impact from an absenteeism standpoint, right? And so we looked at incidents in the community. We began doing surveillance in the workplace, and that led to us being able to understand the community prevalence in the workplace and mitigate and improve our return to work process, right? We even looked at family, the impact from family from an exposure standpoint, and long-term consequences of COVID that led to need, in some cases, to do fitness for duty or make sure that our workforce is safe from an impact standpoint, right? And so that's the same philosophy and approach we want to take when we're talking about the safety to wellness journey, okay? Starting with, obviously what we're used to in EHS, measuring using objective data to help improve the workplace exposure from a hazard standpoint, right? And then provide surveillance to maintain minimal impact to our workers. And so too, do we now want to focus in on the wellness approach, right? Where we use subjective data from surveys paired with objective data, biometrics, and we provide, in partnership with our clinicians, third party, whether we're self-insured or not, interventions that then help drive a 360 risk reduction, right? So we really are talking about a holistic approach to our workforce resilience and wellness. And if we look at kind of our historic charge from a risk mitigation standpoint of safety, when we looked at the measure, the objective data, the on-site intervention and surveillance, it was really about maintaining the workforce health and productivity at the end of the day, right? And obviously by keeping a healthy workforce in terms of minimized impact from workplace exposure, we were able to achieve these 2 bullet points. And so similarly, and more expansively, the risk mitigation from a wellness objective also is to improve workforce health, workforce productivity, but also really focusing in on resilience, right? And focusing in on minimizing the cost burden of the workforce themselves. And if we dial in our focus again to just 3 areas of potential measurement and intervention, we go back to metabolic, cardiovascular, and musculoskeletal, right? And we can then put in place in the workplace basically an approach that helps the workplace become the epicenter for health maintenance for our workforce population, right? There are obviously studies and evidence to show that potentially 40% of the workforce don't have a primary care provider, meaning that they have no one to do screening for these underlying conditions. And we have demonstrated the evidence that these underlying conditions impact directly the risk of workplace injury, right? Musculoskeletal standpoint obviously impacts absenteeism and presenteeism in the workplace as a result of workplace exposures such as shift work, right? And so when we talk about then our ability to effectuate change towards improvement of these underlying conditions, which globally, based upon healthcare delivery in the US, is not improving, worsening. Diabetes is worsening, cardiovascular disease is worsening, and musculoskeletal is worsening, right? And so as a means to intervene in the workplace, we want to continue to move forward from a health protection perspective and increased resiliency. And that's the philosophy that we've learned from COVID, right? And so one of the things we've been doing, or we're rolling out here by means of an example of how we can be innovative in our approach, is to do on-site testing, right? This is basically a mobile laboratory that can deliver point-of-care testing in the workplace with results in 15 minutes, right? And there are a number of companies and approaches out there trying to improve the employer's opportunity to provide metrics around the underlying health and wellness of individuals, right? Again, with the notion that if wellness is going to be the future of how we mitigate risk, providing an opportunity for increased access at the workplace is going to be a strategy that increases return on investment for employers, right? Again, employers already bear the cost of these underlying chronic conditions. So now we are putting in the hands of EHS professionals the ability to both measure and provide coaching to intervene, right? And so again, this on-site presence can look at something like athletic trainers. We've seen the trend in athletic trainers amongst EHS professionals and institutions and employers deployed to help with on-site musculoskeletal interventions, right? And so now using the scope of practice that is already there, being able to then provide metrics around underlying chronic condition becomes something that changes the culture, right? Going back to that study we presented in the beginning of this talk, the culture towards health has to change in the workplace. And by providing then access and quick results, we can then make it a part of normal culture to get these to have this type of screening at the point of care, much like we have done now with COVID, right? And providing then an opportunity to even do, like for example, group-based gamification, where the employer and the on-site clinicians, such as ATCs, aren't necessarily saying, "Hey, Johnny, did you go get your A1C checked?" Right? But they're saying to the group of individuals, perhaps right after they do a huddle for their lockout tagout or a huddle for their safety checks, "Hey, did you guys go get your biometrics yet for this month or this quarter?" right? And it becomes an opportunity where individuals now have an environment and a culture of health maintenance that is different from it exists today because we have better data, more access to objective and subjective data, and by means of that, right, we know what gets measured gets managed, and so we want to be specific in our metrics that we can now at the point of care in the workplace measure, right? And we're talking hemoglobin A1C when we're with regard to metabolic, glucose level, glycolated albumin, right? These are metrics we can measure. Cardiovascular wise, we can measure blood pressure, lipid profile, and see what's called C-reactive protein, a measurement of inflammatory disease around cardiovascular, right? Likewise, with musculoskeletal, we can look at chemistry profile, sodium, potassium, etc. Lipid panel, we again pointing towards the deposition of lipids on tendons, increasing risk for musculoskeletal injury, and we can look at blood lactate levels, right? And so again, being able to, at the point of care, meaning the employer, be able to have 24-hour access, 24/7 access to health data, much like we've seen with the trend with technology, right? Wearables from watches to rings to show and give biometric data to individuals so that we can better manage. That's what we're doing with the employees and the workforce from the perspective of access, and even going to the extent of cancer screening that began already in Europe with European approval and pending FDA approval, right? Where we can screen for ovarian, testicular, lung, colon, and breast and liver cancers, right? And certainly from a resilient standpoint, by mitigating impact from stage 2, stage 3, and stage 4 disease, and discovering these cancers at early stages, even early as stage 1, we are making the workforce more resilient, not just to these underlying conditions, but also, obviously, we talked about those individuals with cancer being increased risk for poor outcomes from COVID, poor outcomes from future illnesses. Let's talk about monkeypox, right? And so we know that by mitigating these underlying conditions, making access to screening more available, we can, in the hands of our EHS, we can then make our workforce a healthier workforce, but obviously more resilient to impacts from pandemics, et cetera, from all aspects of healthcare, right? And so at the end of the day, we want to, talk more about this. We'll conclude for now, but we want to present in our future talks practical ways to then measure the return on investment in your workforce resilient efforts, right? And so it has been an absolute pleasure to present this today, and obviously to have been with you over these past 2 years during COVID to present up-to-date information as well as novel strategies for helping protect your workforce. And in the meantime, while we take our time off, follow me on Twitter, Dr. Anthony Harris, and you can check me out at some of these news outlets that I've been frequenting as you continue to try to seek out what is the best practice for your workforce and mitigating risk and moving forward from safety to wellness. Thank you so much.
Thank you, Dr. Harris. We'll jump right into the questions. Please use the Q&A function to submit your questions. We'll take the first 2 we got before you even started, which are related specifically to COVID. Can you please comment on how much additional morbidity and mortality we see in the US for COVID on average compared to the flu?
Sure. So if we look at COVID in particular, this is a metric we looked at some time ago. It's called, the acronym is PIC ratio or PIC percentage. That's pneumonia, influenza, and COVID, right? And so there is a normal baseline for what we see from an impact of illness and mortality from influenza and pneumonia. And with COVID, we see a dramatic increase in this figure, in this metric, but far above and beyond our normal baseline of seasonality for, again, influenza and pneumonia. And that's an indication that we have still a dramatic impact from COVID. Now, when we talk about the actual percentage increase, have to grab that metric that we presented from a previous during a previous talk, but we are still above our normal baseline for seasonality. Last time we examined that metric, and I can certainly grab what the most recent metric is and present that back here.
Okay. What are the best practices for how long to isolate after a confirmed COVID case to avoid infecting others, including family members? The CDC's guidelines do not feel sufficient, and they don't indicate how to determine if a person is still contagious.
Sure. So there's two factors to this, right? One, the first factor one should consider is symptomatology, right, and severity. So if an individual is still febrile, right, then they are likely infectious, right? So that's the first indication that an individual is not ready, even if it's been longer than 5 days or even 8 to 10 days. If they're still febrile, you're still likely infectious. The other next factor is the temporal factor, right? So if an individual is asymptomatic or symptoms are improving after 5 days of positivity, then the likelihood of them being infectious is far lower than during that 5 day period. And an individual actually can be, an individual can actually be infectious even up to 2 days prior to onset of symptomatology, right? And so again, once you're symptomatic or once you have a positive result, that post 5 day period, you should be isolating to minimize risk of infection. And certainly if your symptoms are persistent and not improving, that too is an indication, even if it's cough or otherwise, shortness of breath, then that's an indication that your viral load may be appropriate levels to transmit to others. And you should still continue to isolate until your symptoms begin to improve or you become asymptomatic after that 5 day window. The 10-day window that we talked about in the past is still in play in some jurisdictions where individuals have to isolate for up to a 10-day period, right? And that practice, again, CDC has moved away from, but we still see it play out. But overall, we see a dramatic drop in risk of transmission after that 5 day mark, given the criteria that I mentioned earlier.
Okay, thank you for that clarification. So based on your presentation today, the question is, should we be changing our COVID-19 workplace approach? For example, contact tracing, daily screenings, etc.
So in terms of changing it towards doing away with it, rather, right now it's still jurisdiction based, right? Still mandated in parts of California and in other parts of the East Coast. But if we're talking about our approach and our charge from a employer standpoint to minimize absenteeism and presenteeism and morbidity, yes, the answer is we should still be doing screening, right? And the screening doesn't necessarily mean we need to be providing point of care testing for COVID, but certainly still providing a means for individuals to signal that they don't feel well. At the end of the day, that it's more perhaps a cultural change that's necessary through systematic approaches of screening than it is anything else, right? If it were a perfect world, right, individuals who have symptoms such as that could be risks for COVID, right, such as upper respiratory, shortness of breath, etc., they would screen themselves out, right? They would stay at home and isolate given the appropriate criteria, right? And what we unfortunately find overall is that even prior to COVID, 94% of the workforce showed up to work sick, right? And so what we want to do is set expectation and make it okay to be home if you are sick. And so that, and one of the ways we've done that is by allowing for screening to happen across the board, right? And it may look differently than it looked in the beginning, where screening was mandated, right? Now screening can be just self-selected, so to speak, right? You participate in the screening only when you have either an exposure or symptoms, and that's when you use your digital tool, most likely at this point, to notify your employer, so that your employer can do the necessary contact tracing that still is going to pay dividends in regards to minimizing workplace exposures. Look, we're still having spikes happen. We're still having, I personally have been a part of scenarios in which at conferences, we have groups of individuals that have become positive through common exposures, right? And so we want to make sure that in the workplace, we're minimizing those opportunities for clusters to happen, and contact tracing, appropriate screening is still going to be a tried and true way to help minimize that risk.
Okay. In terms of night shift workers, have there been any studies done on improvements or prevention in their health conditions using a screening tool such as the one you just presented?
Yes. So not in particular to night shift work, but in particular to modifying the overall burden of disease and cost. For example, we have employers that have done and offered on-site point of care testing for lipid panels, lipid profiles, to reduce the burden of cardiovascular disease in the workplace. And that program has been in place for over a decade, and improvements have been demonstrated, right? And so it is an approach that we know can, if done successfully through adequate participation, reduce the burden of illness amongst the workforce, regardless of their actual workplace exposure status, meaning night shift work, et cetera. And certainly one would then postulate that by means of measurement, right, we can, and mitigation through providing metrics, we can certainly offset the impact from night shift work in those populations appropriately.
Okay, we have time for one more question. And it's a good one, a short question, but an interesting answer. We're all excited to hear. How much of a danger is monkeypox?
Sure. So if we look at monkeypox compared to COVID, right, that's probably what everybody has in mind. Is monkeypox more infectious than COVID? The answer is no. At this point in time, monkeypox, or traditionally monkeypox, or historically monkeypox, is transmitted as a zoonotic disease from directly from animals to humans, right? Kind of a misnomer in the name. Yes, it can come from monkeys, as it was discovered back in, I believe, 1963. But it generally these days is transmitted via rodents, rats, and otherwise, right? In parts of Africa, such as Nigeria and Congo, the Republic of Congo, right? And so usually it's individuals who have traveled and had direct exposure to these said rodents that contract monkeypox. What we're finding now is that means of transmission may be happening from human to human, which is dramatically different from historically how monkeypox has been spread. And it's spread potentially now at this point through human body fluids, whether it's through saliva or through sexual body fluids as well. And because of that, we're seeing the increased spread of monkeypox at a R0, we talked about reproductive rate, right? At a R0 potentially higher than what we've ever seen in the past. Officials are still trying to calculate what that R0 currently is. Typically, monkeypox dies away, so to speak, and never becomes to the extent of an epidemic or even pandemic because of its lack of human-to-human transmission historically. So that change now does offer more of a threat in regards to monkeypox being something that we all need to be concerned about. From an actual mortality standpoint, yes, monkeypox is more fatal than COVID-19 historically as well. Anywhere from 1 to 10% mortality rate for monkeypox. And symptoms of monkeypox that people at this point don't need to be concerned about, but need to be aware of, so to speak, is in particular fever that happens with lymphadenopathy, meaning swollen lymph nodes. And usually about 72 hours to 4 days after fever has subsided, we see the presence of the classic vesicles that happen for monkeypox. And so those factors right now are not presenting a particular increased risk to the general population. But obviously it's on the radar. CDC and other public health officials are continuing to examine and calculate what is the likelihood of an epidemic type spread from monkeypox. And we've even seen the government be very proactive, U.S. government and other governments be very proactive in ordering smallpox vaccine, which has an 85% efficacy against transmission of monkeypox. So as a result of all the kind of factors that are playing out right now, I would say monkeypox is not something we need to be dramatically concerned about at this point in time, but stay tuned and we'll stay abreast so that we can report appropriately how we should mitigate risk regarding monkeypox in the workplace.
Thank you, Dr. Harris. Yes, we're going to be publishing a fact sheet on monkeypox within the next few days. So keep an eye out for that. And all of our upcoming events will keep you posted via constant contact and our website. For those of you who might have joined a few minutes late, just a reminder that we're taking the summer off from this series to give Dr. Harris a break, and we'll be reconnecting in the fall. And over the summer, we'll be doing some other events. So we'd be sure to keep you informed about that. So let's all give a big cheer and thank you to Dr. Harris for everything he's contributed to keep us educated on COVID and related matters since March 2020. And thanks again for joining us.
Thanks, everyone. And as always, stay safe and God bless.